Welcome to this episode of Substantial Matters, Life and Science of Parkinson's. I'm your host, Dan Keller. At the Parkinson's Foundation, we want all people with Parkinson's and their families to get the care and support they need. Better care starts with better research and leads to better lives. In this podcast series, we highlight the fruits of that research, the treatments and techniques that can help you live a better life now, as well as research that can bring a better tomorrow. When the time comes for drug therapy, most people with Parkinson's start off on levodopa. Later, other medications may be added. But at some point, they may consider other treatments, specifically deep brain stimulation, or DBS, or a somewhat newer technology, focused ultrasound. DBS requires surgical implantation of electrodes in the brain, as well as a pulse generator in the upper chest to supply electrical impulses to the brain. Focused ultrasound does not require surgery, but works by aiming high-frequency sound waves at a specific part of the brain responsible for Parkinson's motor symptoms, thereby heating it and scarring the tissue. Each has its advantages and disadvantages, and careful patient selection for either technique is important to achieve the best results. This episode is made possible with an educational grant from Medtronic. I spoke with Dr. Kyle Mitchell of Duke University about these two technologies. He first discussed who could most benefit from DBS and what symptoms it can control.
So deep brain stimulation is really useful for a select set of people with Parkinson's disease with the goal of treating some specific symptoms. The most common would be treating tremor that is either responding or not responding to medication. We would expect deep brain stimulation to have a high chance of helping with that. Second is if medications are working well, but there's some limitations to how they're working, that can present as either dyskinesia, which is a description of wiggling or writhing movements that people can experience when they're on medication, or the ups and downs or fluctuations that people can experience when they're on Parkinson's medicines, where 1 minute they're feeling fine, a couple hours later maybe they're not moving as well. Deep brain stimulation is good at smoothing that out and really maximizing that on or good time during the day when medications are no longer cutting it for that.
Does it address any of the other symptoms, gastrointestinal, slowness of movement, bradykinesia, any of those things?
Deep brain stimulation is really just helpful for symptoms that can also respond to levodopa or similar medicines. So bradykinesia can apply if that's a symptom that's responding for an individual when they take medicine. I would also expect that to improve with deep brain stimulation or DBS. Things like GI symptoms, constipation, or really what are considered non-motor symptoms like cognitive or other symptoms are not expected to improve with DBS. So we're looking at motor or movement-related symptoms that respond to Parkinson's medicines and also tremor regardless of whether or not it responds to medicine.
Are there any one or more predictors of good outcome with deep brain stimulation?
Yes, there's several predictors for who's going to do well, and a lot of that is really quantified or calculated when we're trying to see who we think this would be a good idea for. The biggest predictor is how well someone responds to levodopa. The way we assess this is have someone come in completely off their medications, and we can get a scale which assesses how bad things are, like tremor or stiffness or slowness of movements. And then we have that person take medication, take levodopa, and then record that same scale when they're optimized, when they're feeling on medicine. The people that improve the most from that off state to on state are the people who are also likely to have the more dramatic improvement when they undergo DBS and DBS programming. And then people with tremor in general also do well with DBS.
I guess a very basic question would be, what is DBS? How's it done?
So DBS is a surgical procedure that's done by a neurosurgeon with or without the help of a neurologist to help localize the procedure. I guess it's best thought of as a pacemaker for the brain. So it's a way that we can modulate brain rhythms in order to make them more normal. So in Parkinson's, we see when we're recording people's brains that the brain can get out of rhythm, much like a heart could get out of rhythm. And the DBS is using electricity to restore a more normal brain rhythm, just like a pacemaker would for the heart. What it is physically is small electrodes, which are about as wide as the end of a pen, which are placed into very specific spots in the brain, which are known to be involved with Parkinson's symptoms. And then we connect those electrodes or wires to a small computer and battery pack that we can adjust. And we can make those adjustments to normalize that brain rhythm. And when we do that, it helps with those motor symptoms of Parkinson's.
Does patient age affect predicted outcomes with DBS?
That is somewhat of a topic that is not fully known. I think the trend has been that people that are younger more reliably do well, but I'd say it's somewhat controversial in the literature. There have been several studies that have shown people in their 70s and even people in their early 80s still having quite a good response with DBS. Other medical issues can come up the longer someone lives with Parkinson's that could make surgery more risky. Things like heart disease or lung disease, or trouble with anesthesia, or maybe memory problems. So age is really a relative term when it comes to DBS. It depends on how healthy the person is, regardless of age.
What's coming along in DBS? We see all sorts of electronics in every sphere getting better over time. What's going on here?
DBS has really undergone a big explosion in technology really over the last few years, primarily triggered by a few different companies entering the market and creating different ways of doing DBS. So I could focus on a few things. One is directional DBS. And so this is DBS where the doctor, the neurologist can steer the electricity in the brain instead of just stimulating the electricity all around the wire. And so that allows the neurologist to focus the electricity in the brain just where it's needed. So it's very targeted, very individual. And this seems to reduce the chance of causing side effects from that electrical stimulation. Another innovation has been rechargeable batteries. So batteries deplete, batteries die, that's what they do. And typically with DBS, people would need a new battery every 3 to 5 years, which required a minor surgery to replace it. But with rechargeable batteries, someone can have the same battery for up to 15 years. So that's been a really nice addition. The last thing is really new to the market called brain sensing DBS. And so this is a new technology that allows the DBS to record the brain of a person. And so neurologists can find those bad brain signals or those bad rhythms in the brain, and they can use that information to better program the DBS to treat those.
AI is a big topic. Do you think at some point the DBS units will reprogram themselves moment to moment depending on what's going on?
It's a very exciting topic within DBS and an area of a lot of ongoing research. That's a field that's called adaptive DBS. I think artificial intelligence is a little too far. I would think of it more as DBS that can adjust on the fly according to someone's brain signals. The thought behind that would be people probably don't need the same amount of stimulation when they're sleeping or when the medicines are working well. So DBS would be better if it would adjust only when the patient needs it and then kind of turn down when the patient doesn't need it as much. I think the best way to think about that would be thinking about a thermostat in your house. You set it to a temperature, we'll call that good control of tremor or good control of stiffness. And that thermostat only turns the AC on when it gets hot enough in the room. And then when the temperature is ideal, that thermostat turns off. We would envision the DBS doing that in the same way, turning on when it's needed and then turning off when the brain rhythms look more normal.
Why don't we turn to a different technology, which is focused ultrasound or FUS. How is that different from DBS and how's it done?
So focused ultrasound is a relatively newer procedure, just over the last few years. This is different from DBS in that it doesn't involve hardware implanted in the body. It doesn't involve a computer or a battery in the body. This is done by using an MRI, so a scan of the brain, to find the specific brain target, and then using high-intensity ultrasound, just like the ultrasound you see in other technologies, but this is so high in intensity that it can actually heat up a very small target in the brain, similar to the targets we use in DBS. And when that part of the brain heats up enough, it creates what's called a lesion or a scar in the brain. And it turns out that if you make a lesion in a spot, in a specific spot in the brain, it can actually help symptoms like stiffness and tremor. So I would say the biggest differences are you don't leave anything in the body when you're done. It doesn't require making a hole in the skull so that a wire can go in. It's all done outside of the skull. Another key difference is that it's only really done at this point for one side of the body, due to concern that if it's done on both sides of the brain, for both sides of the body, that there's a higher chance of side effects or complications from it. So it's typically done just if someone has a lot more symptoms on one side versus the other. What's interesting is that focused ultrasound is somewhat of a new way of performing an old surgery. So these lesions or scars were actually made in the same areas of the brain back as early as the 1950s and 60s. The main difference was that was using a wire that went into the brain and heated up until it made that lesion or scar. Focused ultrasound is doing at its core the same thing, but it doesn't require placing instruments into the brain or making that hole into the skull. So I think a new, more eloquent way of doing a somewhat older procedure is the best way to think about it.
When I was a kid, I saw on TV they were doing very early cryoablation on a woman for Parkinson's with refrigerated or cooled alcohol in some sort of device that would go into the brain. So I guess that was a real forerunner of this sort of stuff.
Very interesting. And those lesions were actually performed even before levodopa was discovered for Parkinson's. So for a time, they were the only treatment for motor symptoms of Parkinson's. They kind of went out of favor for a while after people were doing so well with levodopa and other treatments. So this is really a neat resurgence of that and made possible with this new technology with the focused ultrasound.
The one thing focused ultrasound does, which DBS doesn't, is it wipes out a specific spot in the brain. So I take it it's irreversible.
That's right, and that's a good way of looking at it. I don't like to talk about focused ultrasound as a non-invasive procedure, even though you're not leaving hardware in, because you're still making a lesion or a scar, and by definition, a scar is not reversible, and it creates that small area of damage there. So it's something where if it's done, it's there. It either works or it doesn't. That lesion has been made.
Why would you choose DBS versus FUS or the reverse in a patient?
I think a couple reasons for either. I'll talk first about focused ultrasound, since I think it's newer and maybe a little more controversial on who would benefit and who wouldn't. I see focused ultrasound as being best for someone with really asymmetric symptoms, so symptoms that are much more severe on one side of the body. And this person maybe really wants to avoid having implanted hardware in their body for whatever reason. That may be someone who does better with focused ultrasound. I think DBS would be best for someone with Parkinson's disease who's okay with that hardware, and they'd benefit from the option of treating both sides of the brain for both sides of the body. And they like the idea of adjustability over time, understanding that Parkinson's changes and worsens as time goes on, and having that ability to adjust the computer and adjust the stimulator to address those symptoms. I think some surgical patients will be candidates for focused ultrasound, and the majority will undergo DBS for the time being. But a big caveat to that is DBS has been around for 20 years, and I think early on, it didn't really look like what it looks like now, and there's been a lot of technological improvements. I would expect that to be similar for focused ultrasound and really any new surgical method that comes around. There's always room for improving it, and maybe that group of people who would benefit from it will expand as time goes on.
With today's technologies for either of them, what kind of long-term results or benefits can people expect? I understand every patient is different, but do these things lose their effect over time?
That's a really great question. We certainly have more data when it comes to DBS just because we have people who've been treated with it for decades as opposed to just a few years. With DBS, on average, it's still going to treat those same symptoms that improved initially, tremor, stiffness, and slowness. It's still going to treat those throughout the life of the person. But the Parkinson's is still getting worse slowly in the background as time's going on, and certain things may come up, maybe worse in balance, worse in memory, more freezing of gait, meaning the feet kind of getting stuck to the ground, and maybe those things never responded to DBS for that person. Those things wouldn't be expected to improve. And so that's another way of saying just new issues may crop up that are not going to respond to the DBS that's already there. But the main reasons DBS was initially implanted for a person, tremor, stiffness, dyskinesia, would expect it to continue to gain improvement or continue to have some symptom control as time goes on, and that's over the course of years to decades. It's not a cure for Parkinson's. These things can and do get worse as time goes on, but those specific symptoms that DBS is treating will continue to be treated.
So much of this is gauged, its efficacy, based on the Unified Parkinson's Disease Rating Scale Part 3, the UPDRS Part 3, which measures motor function. Is it really better to look at overall quality of life, which would take into account motor function and side effects and really functioning after either of these kinds of technologies were applied?
Absolutely. And you're right, a lot of the times the main outcome that's been evaluated is, how does someone look from a motor standpoint, tremor, stiffness, but what does that really mean for quality of life? Fortunately, with those really early large studies, those things have been evaluated. With the initial DBS studies, very large trials in Europe and in the US, the main outcome wasn't how does their score on the UPDRS improve, it was how many more hours of on time or good time per day does a person have? And they found a very dramatic improvement of about 4.5 hours of more on time per day. And this is in the early days of DBS. There are also scales that assess quality of life. There are those other parts of the Parkinson's disease rating scale that look at quality of life and reactions to medication, side effects of medicines. And fortunately, those also improve with DBS. So it's been nice that when these large studies were done, they really looked at quite a few outcomes. And so while people really think about what percent does someone improve on their motor rating scale, these other outcomes have been shown to get better with DBS in carefully selected patients where we know there's a decent chance for success based on our experience with it. Same thing with FUS, focused ultrasound. The UPDRS is certainly looked at. The same quality of life surveys are also evaluated in that, and there's definitely been indications that it's helping in those areas as well.
Have we missed anything that's interesting or important to add?
I think one thing that anyone will think about when they're considering surgery for themselves or a loved one would be, what are the risks? Any kind of surgery has risks that come along with it, whether that be risk of stroke or hemorrhage, which you can see, which is hovering around that 1% to 2% chance. Infection primarily with the DBS, with the implanted hardware, would be a 3 to 5% risk. Infection, not as much of an issue with the FUS, the focused ultrasound. However, in a recent study with focused ultrasound, there was concern for some long-lasting side effects that could last months, even up to a year in some people. Side effects like clumsiness on the treated side, low numbers, but still, 5 to 10% of people having that. Speech issues, which maybe lasted a couple of months and then eventually got better. These are not minor. These are significant side effects that can happen with surgery and something that definitely needs to be taken into consideration before undergoing either. And they really have different side effect profiles, as I've mentioned. So maybe a higher chance of infection with DBS, higher chance of persistent speech issues or clumsiness or dyskinesia with the focused ultrasound at a year. And we don't know if those eventually go away, but certainly they're a good long time. So it's just important to know that there are risks with any surgical procedure, and before undergoing any of them, I would recommend any person with Parkinson's to get a good idea of what those are before going into it as they're making their educated decisions on the best treatment.
Very wise advice to end on. Thank you very much. This was informative. I'm sure people who are getting to the point of considering either, this will help them kind of put them in perspective and sort them out. For more on DBS, go to our online library at parkinson.org/library and choose Deep Brain Stimulation in the topic drop-down menu. You'll find fact sheets, relevant podcast episodes on the subject, and videos featuring our National Medical Advisor, Dr. Michael Oken, on how the DBS device works, risks and benefits of the surgery, what family members need to know about it, and who is a good candidate for DBS. You can also download our book titled Surgical Options, which includes focused ultrasound as well as extensive information on DBS. The book concludes with a section on what developments are on the horizon, appendices with useful suggestions and advice, and a glossary of common and technical terms. If you're considering DBS or focused ultrasound, You may find other people with similar interests or who have experience with one of these therapies in our online PD Conversations section at parkinson.org/PD Conversations. You can even pose your questions to experts. If you have questions about today's topic or anything else having to do with Parkinson's, our information specialist can provide answers in English or Spanish. You can reach them at 1-800-4PD-INFO. News and updates about future events and resources are available by joining our email list at the bottom of our website's homepage. If you want to leave feedback on this podcast or any other subject, you can do it at parkinson.org/feedback. If you enjoyed this podcast, be sure to subscribe and rate and review the series on Apple Podcasts or wherever you get your podcasts. At the Parkinson's Foundation, our mission is to help every person diagnosed with Parkinson's live the best possible life today. To that end, we'll be bringing you a new episode in this podcast series every other week. This episode is made possible with an educational grant from Medtronic. Till next time, for more information and resources, visit parkinson.org or call our toll-free helpline at 1-800-4PD-INFO. That's 1-800-473-4636. Thank you for listening.